I just want to mention for those who are new to our series, I usually put on my slides my name, Dr. Donald Jurovich. If you have not attended these before and don't know who I am a professor of geriatrics at the University of North Dakota. And I'm also the principal investigator for what we call the GWEP, the Geriatric Workforce Enhancement Program. And this is intended to provide educational sessions like we're having today, as well as to help transform primary care into what we call age-friendly healthcare. And so age-friendly healthcare involves fundamentally the application of the geriatric 4 M's. And I apologize for those that have heard this before, but just to emphasize that the 4 M's are what matters, mobility, mentation, and medications, and that by addressing these 4 primary issues in the geriatric or older adult population, that we will generate better outcomes for the older adults. So that's the intention. Some people actually talk about 5 geriatric M's, with the 5th one being medical complexity. Okay, so if we can have the next slide. Today we're going to talk about mentation and mild cognitive impairment. And excuse me, the goals today are to define mild cognitive impairment. We want to look at the epidemiology and what the risk may be, as well as how to diagnose mild cognitive impairment, and then also what the treatments are. So the next slide, please. Yeah, so just to reemphasize that we're talking about the 4 M's in healthcare. And also this is our logo. For those that have not seen this before, it's called, we call our GWEP, the Dakota Geriatrics Program. And just to mention that we have the standing oak tree off on the horizon with the setting sun and the flying eagle, or rather hawk, in the sunset there to help represent the last phase of life, or the latter phase of life. Okay, next slide, please. So mild cognitive impairment is a syndrome. It's generally thought to have a subjective component, like people will complain that they're having memory loss, or they're forgetful. And it then becomes mild cognitive impairment if there's what we call an amnestic component to it. So there's individuals where somebody says, oh yeah, they do forget things, like they're forgetting their keys all the time. So that would be amnestic MCI, and it's documented. And the diagnosis of mild cognitive impairment is that there are cognitive declines in different domains. And so, if you get somebody who, let's say, is a college graduate, they have a college degree, or let's say even further, they have a graduate degree, but they say something's just off. Well, a lot of times what we'll do is we'll have them evaluated by a neuropsychologist, where they do multiple domains of testing. So they'll test for executive function, they'll test for spatial function, math, reasoning, judgment. All these are different domains, language. And so these are things, ability to convert numbers into symbols and to follow through on tasks like that. So symbol conversion tasks. These are all different elements that help measure the different cognitive domains for diagnosing MCI. Now, unlike dementia, the ADLs and IADLs are preserved. So those are the activities of daily living and the instrumental activities of daily living. So as we know with I don't want to call it garden variety dementia, but typical dementia is often associated with a decline in, firstly, the IDLs. These are typically instrumental activities such as shopping or paying the bills. A lot of times you'll see people forget to pay their taxes. and they get their house repossessed. So that would be a type of IADL that declines with Alzheimer's and related dementias. So you don't see that in the mild cognitive impairment. Their functionality is preserved. But I just want to make the point that with time, individuals that do have frank dementia, their cognitive decline usually is in parallel with their functional decline. So if they have a lower functional status, they usually have a lower cognitive status. Although I have to say that since I've been in North Dakota, I've actually observed a disconnect. I find that there are individuals that have moderate dementia or cognitive impairment, but have fairly highly preserved functional status. And I don't know quite what that is, but it might be some form of resiliency that's associated with the population here in the North. I'm not quite sure, but I just share that clinical observation with you. Next slide, please. So this is the prevalence of what we call subjective cognitive impairment. And you can see that, when self-reported, that there's a steady increase with age. So typically we consider on the left there, that light green, young, old individuals, those are 65 to 74. And then it bumps up by 5% more with the old, those are 75 to 84 years old. And then in the orange are the oldest old, so up to 35 to 36% thereabouts of the oldest old will complain of some subjective cognitive impairment. It may be something like tip of the word or tip of the tongue, trying to find a word, searching for words, or again, some cognitive lapses, some memory lapses. Next slide, please. So by comparison, the prevalence of objective cognitive impairment with either memory or other cognitive functions is a little bit less, and again, a little bit more evenly distributed amongst the older population, as you can see here. Next slide, please. So if you break it down into smaller age groups, you can see that there's a steady, somewhat exponential increase in the prevalence of mild cognitive impairment per age group. And so you can see that basically 1 out of 20 in the young old experience some form of mild cognitive impairment, and going up to basically a little over 1 out of 3 individuals who are older than 85. And that matches pretty closely to the distribution of Alzheimer's disease too throughout these populations. So we're talking about two different things now, mild cognitive impairment versus dementia, but they have similar patterns of prevalence. And I also want to point out, just from the onset, to make sure it's clear that people who have mild cognitive impairment, not all of them progress to full dementia. It's about 50-50. So it's important to understand this as a diagnostic domain, so that we can do interventions that to prevent the progression of mild cognitive impairment into a full-fledged dementing illness. Next slide, please. So again, the prevalence is a little bit higher when you have subjective measurements, but then when you objectively measure the mild cognitive impairment, it's the range is 2 to 20%. There's no predilection for male or female. It seems that perhaps African Americans have a slightly higher prevalence when populations are compared, and diabetics also. And that's an important point, because diabetes is considered a risk factor for Alzheimer's disease. Next slide, please. So we have this back and forth, the arrows. Mild cognitive impairment, right there, smack dab in the middle, may progress from two dementing illnesses, or alternatively, in the bottom arrow is that it could revert back to normal aging. And so the question is, what the dynamics are for that. It's very similar to conceptually for frailty. You get people who are frail, and they some of them progress to full frailty, and others progress back to pre-frail status or non-frail. So again, if you ever were in chemistry class in college, you would see this equilibrium equation with the arrow pointing in one direction versus the other. And it's, for us as healthcare providers, we would like to make that yellow arrow a little bit bigger and move most of that MCI back into normal aging. Next slide, please. So again, the progression of not all mild cognitive impairments progress to dementia. It's about 10% per year conversion rate. And if the conversion does occur to dementia, it will be so in the first, the second or third year, and much less after the fourth and fifth. So usually the point of, I don't know if you want to call it the point of no return. I don't. Hopefully, nothing's a point of no return in terms of trying to intervene in these illnesses. But usually, the window is noticed within 2 to 3 years for these individuals that are expressing problems with their memory or other cognitive lapses. Okay, next slide, please. So this is somewhat of a slide that shows the declining cognition, over time. And this is a conceptual framework where you want to look at the preclinical elements of that. So this would occur with brain changes without measurable symptoms. And it reminds me of one of the studies that was done in Europe, where they were looking at the what was called the MIND diet. So it's a Mediterranean forward diet. And the population was cognitively intact. They had no cognitive problems. But one group was on the Mediterranean diet, and the other one was on a regular, ad lib meat forward diet. And they measured brain volume. And of course, brain volume and brain shrinkage is associated with dementia. And the people that were on the what we call the omnivore diet, or the meat forward diet, had considerable brain shrinkage over a 5-year period, but they didn't have any symptoms. So it was just a neuroanatomic finding. So that would be an example of a preclinical expression of cognitive, not cognitive changes, but brain changes without symptoms. And then as this process progresses, we go into mild cognitive impairment, where it's either subjective or objective measurements of cognitive changes in one or more of the domains of cognition. Again, those domains could represent language. They could represent arithmetic. I mean, you'll find people when you do a serial subtraction of sevens, for example, they can hit all the subtractions perfectly. But then you ask them to remember 3 words, and they can only remember one of the 3 words. So there's different domains that are impacted. And again, with MCI, the important point is that there's preservation of activities of daily living. And then as we move on into the dementia states, there are the mild, moderate, moderately severe, and severe stages of dementia. And again, these are significant enough changes that they interfere with everyday activities. And again, you can measure those either through the instrumental activities of daily living. Sometimes we measure them by driving ability. If somebody gets into repetitive accidents, near misses, gets ticketed for unsafe driving, these sometimes are indicators of loss of function and driving ability. Next slide, please. Well, this is a little complicated, And I put this in there just to show that not everything is Alzheimer's disease. Okay, so there's different kinds of dementias, and they often intersect, so that we know that there's mild cognitive impairment that intersects with all of these conditions. And so you could have a vascular related dementia, and it could be progressive, maybe incrementally, which might be very different than Parkinson's dementia, but they all may have this pre-prodromal phase of mild cognitive impairment. So again, one type of dementia is not always a pure dementia. You might have elements of both vascular and Alzheimer's dementia, and that's what these Venn diagrams are supposed to represent. Okay, next slide, please. So if you ask what the predictors of mild cognitive impairment is and what the conversion is to dementia, so age is one of those. And so if you have an 85-year-old, they're more likely to convert from mild cognitive impairment to a dementing illness than a 65-year-old. And sometimes that's why we have to differentiate between depressive symptoms, frank depression, and dementing illnesses. So if somebody has neuropsych testing, delayed verbal recall, so again, not remembering those 3 words or 5 words that are presented, problems with visual recognition memory, so remembering different either pictures or association with pictures, and or somebody that has an instrumental activity of daily living problem where they may need some assistance with their finances, maybe shopping, would be the 2 most likely deficits that you would see. And again, I had mentioned about paying the taxes, right? So if somebody just can't get their tax act together, that could be a IADL deficiency that may suggest mild cognitive impairment converting to dementia. Okay, next slide, please. There's some psychological predictors of mild cognitive impairment. So as I kind of alluded to, depressive symptoms or depression may be a precursor to dementing illnesses. Almost I would say uniformly, there is a depressive phase before people are recognized as having full-fledged dementia. Loss of interest, apathy, as well as anxiety, and just this general feeling that things aren't right, this dysphoria, this, things are just, there's something wrong, perseveration. These are all psychological factors and can be predictors of conversion of MCI to dementia. So again, evaluating the behavioral elements in clinically assessing people is really an important element to being able to get an estimate or a predictor of whether they're going to convert to dementia or not. And there's not a lot of data, by the way, in terms of whether treatment of, let's say, anxiety with medicine, prevents the conversion of MCI to dementia. And I just want to share with you, I know Dr. Minocha will smile at this, but I just read a recent study, a 2021 study from Australia, where they were using turmeric and curcumin as a preventer of converting MCI to dementia. And the study was not very long. It was only a couple of months, so they really didn't have enough data over time to make any conclusions about whether it prevented the thing. But they did find that individuals on the turmeric rather than the placebo had less anxiety symptoms. And so it's the first time that I've ever seen a plant medicinal that has been associated with it as an anti-anxiety. Although I take that back. I guess St. John's wort also does that. So there is a precedent for plant medicinals having effects on behavior and mood. Next slide, please. This is a big one in terms of physical performance predictors. So Dr. Verghese from the Einstein Medical School has discovered that slow gait is associated with future cognitive impairment. So there's a twofold risk of slow gait. He calls it the motoric cognitive risk syndrome, and that it affects up to 10% of the older adult population. Again, 10% representing everyone from 65 to over 100 years of age. And it increases, so gait speed declines with increasing age. So as you can imagine, the 90-year-olds who have really, really slow gait speed for age match controls, they then too would also be similarly at risk for MCI and the link to slow gait. What remains to be seen is whether if you speed people up and get them into a program to walk faster, whether it prevents the conversion of MCI to dementia. Still remains to be seen. But I often am amused when my wife and I go walking, and I walk very, very fast, and she's always complaining that I walk too fast. And when I explain to her why I'm walking fast, she walks even faster than I do. So a little bit of incentive there. Next slide, please. All right, so there seems to be some connection between your ability to smell, and of course, now that we've got COVID, knocks out your smell, that there seems to be smell impairments associated with increasing dementia risk. And so, again, people who have abnormal smell or smell sensation or olfactory, if they have no evidence of cognitive impairment, they still have a twofold risk of converting into minimum cognitive impairment, whereas those that already have established amnestic memory loss, minimum cognitive impairment, and if they have an olfactory deficit, and again, they use different scents for that they have a fivefold risk of developing dementia. So some people use olfaction. I don't know if you remember, but there was a product that Walgreens Pharmaceuticals had produced. It was an olfactory test, and if you couldn't smell certain of the odors, they said go see your doctor for memory testing. But that's never really panned out, quite honestly. And these tests are not used routinely. We actually used a sniff test in nursing homes, a couple of nursing homes that we collaborated with to identify COVID symptoms. And they did not find any individuals that had COVID, but they did find people who previously had COVID, and they were using the sniff test to see when they recovered their sense of smell. So I thought that was kind of an interesting turnaround in using the sniff test. Next slide, please. So there's some research, as to whether there are biomarkers, either brain markers or peripheral blood markers, that would identify risks of MCI conversion to dementia. And these are always of great interest, because if you could not only find the markers, then you could monitor those markers to see if your clinical intervention, we talked about turmeric, for example, whether that favorably impacted or reduced those markers. So that's why there's a lot of interest in this. Next slide, please. Excuse me, I just had to take a little sip here, clear my throat. So ApoE4, we've heard about this. It's linked to dementia and minimum cognitive impairment, but it has no predictability of converting mild cognitive impairment to dementia. So I think that's an important fact. Some people will come to clinic and they say, my mother had Alzheimer's when in her 60s, and I'd like to be tested for the ApoE4. And, there's always this controversy about if you get the ApoE4 evaluation and somebody is positive or what we call homozygous so they have both genes, have the ApoE4, both chromosomes. Then the question is, what do you do about that? And does that put the patient at risk for, issues such as depression or quite possibly even suicide, knowing that they have the ApoE4, and that's why a lot of times we don't push for that genetic testing. However, for those that are concerned about ApoE4, there probably is a good rationale for using very strict cholesterol management or aggressive cholesterol management, because ApoE4, is basically the carrier for cholesterol, and cholesterol can be toxic to brain cells. So that's why we always talk about good cholesterol management as a prevention of Alzheimer's disease, and which, by the way, may be one of the reasons why vegetarians have less Alzheimer's disease than omnivores. It may have something to do with the cholesterol load over the lifespan. Okay, next slide, please. So we know that there are disease linkages to MCI and to dementia. So the metabolic syndrome is, something that, you see those individuals that are overweight. They have a high BMI, usually over 30, and they're either pre-diabetic or diabetic, and then also diabetes. So the HR here stands for the hazards ratio. So, you've got roughly, you could say fourfold or twofold increase in association with dementing illnesses if you have these conditions. And both of these are highly preventable by diet and exercise. And so you can imagine, what an impact you can have by aggressively addressing these two conditions as a means to prevent MCI and dementia. Okay, next slide, please. So getting back at the markers. So again, diabetes and obesity are general markers, physiologic markers for MCI. But people have looked at these proteins in the spinal fluid called tau, or the phosphorylated version of tau. They found that there's actually low levels of beta amyloid. So beta amyloid 42 is the one that everybody attributes to dementia. But in the spinal fluid, it's actually low. And some people speculate that maybe that's because the brain is not clearing it out into the spinal fluid. People have looked at ratios of the different types of amyloid beta, and there's really not much to comment about that, although some people will hang their hat on these ratios being off in the spinal fluid. Next slide, please. So another question is about neuroimaging. So some people look at brain atrophy, they look at hippocampal volume, and different types of tracers that you can use to look at the brain. So we have a very colorful brain here. This is not real neuroimaging. This is an artist's version. So if we can have the next slide, please. So basically, we talked about brain atrophy. So you can see here, there's an MRI, and we're looking here at the temporal lobe, which has some shrinkage. You can see that by those little sulci, those little convolutions going back and forth. And so the distance between those and each other one, and the distance between them and the skull is representative of brain atrophy. Next slide, please. Another test is the PET scan or functional MRIs for changes in brain metabolism. And so generally they look for decrease in sugar metabolism or other metabolites. And they find that if a PET scan shows impaired the PET scan plus impaired episodic memory, like you can't remember events, that there's a 11-fold conversion rate from MCI to dementia. Of course, there's also amyloid PET scans, and that if there's high retention of the tracer that tracks the amyloid, That's also considered predictive of converting MCI to Alzheimer's disease. And then people are also now looking at what's called a tau marker, tau protein. So that's the part that's they talk about neurofibrillary tangles and tau protein in the cell with the granules, but there's no research to really say in one direction or the next as to whether tau accumulation is a predictor of dementia. Next slide, please. So when we talk about the diagnostic workup, we firstly and always want to look at the reversible causes. I can't tell you how many times we forget about medication side effects. One of my favorite clinical encounters was a individual that had mild cognitive impairment. And I said, that tramadol that you take each night causes memory loss. And she says, well, I don't think we need memory loss. So she decided that she didn't need the tramadol as bad for a sleeping aid any further. So that was good. But, identifying moments of deprescribing benzodiazepines and some of the Parkinson's medicines, so the dopaminergic medications, both of those can cause amnesia. So the dopaminergics can cause both retrograde and anterograde amnesia, as well as the benzodiazepines. And so they definitely affect memory. So we have to figure out whether that has any connection. Another big one is obstructive sleep apnea. And so people very rarely say, oh, they don't come into the clinic and say, I've got obstructive sleep apnea. Usually it'll be a spouse that will report frequent snoring, lapses in breathing, so the breathing stops, and those would be key indicators. As mentioned earlier, depression is a premonitory symptom that can cause cognitive impairment, and if treated properly, the depression and the memory loss associated with depression disappears. I actually had a colleague back when I was in geriatric training who couldn't remember all these different clinical things, and the individual was just clinically depressed, couldn't even balance a checkbook, and this was like a 30-something physician at the time, and once adequate depression treatment was initiated, everything went back to normal. But it just, again, really highly reinforced my clinical understanding of how depression can cause cognitive impairment. The other two, are looking at B12 deficiency and hypothyroidism. I would add that in diabetics, we look for folate deficiency because people that are on metformin and are diabetic often will have a low folate level. And so we're interested in identifying that. Next slide, please. Just to continue with the diagnostic workup, we want to look at either the Montreal Cognitive Assessment Test or the what I prefer is the SLUMS test. And so the minimum or mild cognitive impairment usually represents a score of 21 to 26 if they've had high school or better education, and then you subtract the point off down for if they are less than a high school education. We know that there's other quick screening tools that are listed here. I don't quite honestly use these, so I don't want to really comment. I just wanted to make sure that we had a full representation of some more rapid tests. I mean, quite honestly, the SLUMS test takes less than 5 minutes. But sometimes in the clinic setting, it's important to have something a little bit quicker. And there are specific tools for mild cognitive impairment screening, such as you see there. And those are the references, the DOI numbers. So you can look those up and see if they're of value to your clinical practice. Next slide, please. Yeah, so this is just representations of the MoCA on the left. Like I say, I've kind of converted over to the SLUMS examination. But I'm very fond of the mocha, particularly with the camel. And if somebody tells me that it's a dromedary, I give them an extra point for knowing that. So that's my own little 2 cents worth on the mocha exam. But I want to point out in both of these exams, you can see there's visual spatial components, and so there's clock drawing, for them, drawing a cube. And so it turns out that there's some studies out of UCLA, for example, with the cube drawing, that is the first element of visual spatial changes that is identified with Alzheimer's disease. And likewise, the clock draw can also be an evaluation for what we call executive function. So again, bringing your attention to the left with the MoCA, the trail test, where you connect the dots with 1 to A, 2 to B, and the cube test. Those are actually measurements of executive function. And one of the primary definitions of Alzheimer's disease is loss of executive function. And so to the slums exam on the right side here, you can see that the clock draw and then identifying the largest object there, or identifying what shape an object is, those are also indicators of executive function. Next slide, please. Oh, this is one of my favorite studies. It's called the SPRINT trial. And it's evident that with aggressive treatment of cardiovascular risk factors, and we're talking about both cholesterol management and blood pressure control, that those are highly valuable for preventing dementia and mild cognitive impairment. So the new goals from the SPRINT trial is to bring the blood pressure down to 120. We're much more permissive in usual clinical practice. If anybody over the age of 65 has a blood pressure of 140 or less, we consider that pretty good. But if they're very functional individuals, at least in my clinical practice, we tend to get a little bit more aggressive and try and target 120 as the ideal blood pressure. And it's all based upon this SPRINT trial. Next slide, please. Other interventions that are ongoing are the Mediterranean or MIND diet. So the MIND diet is a combination of the Mediterranean and the DASH diet. So low salt and vegetarian forward, so vegetable and fruit forward, with fish is the Mediterranean diet. There was just a recent publication in JAMA that talks about how much salt we consume. So the recommended amount of daily salt intake is 2,300 milligrams per day. And on average, older adults consume close to 4,000 grams of salt, so almost twice as much. And so I think that's an important consideration too, in terms of reducing cardiovascular risk. 85% of people with high blood pressure can benefit from radical salt reduction. And so I think it's just kind of a point to make in terms of small changes that we can make in diet to improve our health. Also, in terms of physical activity, patients who have been diagnosed, again, that score of 20 to 26 on the slums test, they can gain an extra point after a regular aerobic training exercise. It still remains to be seen about adding resistance training to that, which I think is important in the older adult population. In terms of cognitive training programs, there are some evidence that they help, but they're not dramatic in their impact. But taking all three together here, nutrition, physical activity, and cognitive training, I think are all important elements in terms of your prescription. Next slide, please. Oh, I wanted to mention about dual task training. This is important. So even though this might not particularly help cognition, dual task training for what we call postural stability is where somebody, when they're walking, will count backwards or say the alphabet backwards. And these are ways to distract the cortical processes, and it forces the brainstem to pay closer attention, if you will, to gait and balance. And so it's one methodology for decreasing fall risk in the older adults. And I'll just put a plug in for the other intervention is to make sure that people, when they're walking, don't wear their bifocals. They should have distance glasses only, because there's new evidence that suggests that with the bifocals or progressive glasses, that your ability to recover from a postural perturbation is reduced considerably. Next slide, please. Yeah, so the medications that we use to treat dementia, such as the acetylcholinesterase inhibitors, those are Aricept, rivastigmine, galantamine. They're not to be used in MCI. They have no impact on the conversion from mild cognitive impairment to dementia, and they happen to have a lot of gastrointestinal side effects. Also not recommended are things like Aleve, Motrin, ibuprofen, or aspirin compounds. There is some evidence that chronic use of aspirin and Advil type compounds has a lower expression of Alzheimer's in some studies, but in terms of prospective studies, nobody's found any intervention. And the only thing I'll say is that I personally have an interest in salicylic acid, which is yet an untested territory for preventing conversion of MCI to Alzheimer's, and it works by a totally different mechanism than the other NSAIDs. So even though you're not supposed to prescribe any of these, and I don't suggest prescribing salicylate either until the studies are done, but the book is not closed on the role of anti-inflammatories in preventing Alzheimer's disease. Next slide, please. Okay, so some of the other things that there's no randomized controlled trial that shows that ginkgo biloba works. There's lecithin, so these are phospholipids. Mixed results. Some studies show they work, some don't. Mostly they show that they don't work. Fish oils, and again, these are fish omega oils and not necessarily, nobody's compared like flax-based omega oils, which flax has more carbon double bonds than the fish omega oils, so N3 versus N6. So the verdict is still out on the omega oils, but definitely fish oil supplement doesn't work. And there was a study quite a while ago that showed that high dose vitamin B complex prevented conversion of MCI to dementia, but then on revisiting that study, it showed no impact whatsoever. Next slide, please. So some of the things for amnestic MCI, look, people are looking at intranasal insulin, growth factor, and I'd mentioned earlier turmeric, which is in the picture to the right. So some of those studies show that in cognitively intact individuals, that it helps with verbal memory, visual memory, and attention, as tested by the Trail A test. So that's connecting the dots and the speed with which you connect those dots, going from 1 to 2 to 3. Next slide, please. So just as a reminder, there are different stages of dementia. And the next slide. And I think we're pretty much towards the end of this, where this shows an artist. You may have seen this before, as to the different stages going from mild to severe dementia, as to how his visual spatial sense of his self-portrait really altered dramatically over time. And so this gives us a little bit of an insight about the inner workings of our of the dementia patients and what they see. And if you look at that last picture there in the bottom right, you can only imagine how Alzheimer's patients see other people, in this distorted view. So every little bit of body language is so representative. So if you have somebody that has agitation, you don't want to have a furrowed eyebrow. You don't want to have a frown because that's going to tell them that or convey to them that you're angry or that they're under attack. And so that's why it's always well to have kind of a happy smile, expressive face to help disarm the older adult with dementia. Let's see if we have the next slide. I'm sorry. Yeah. So I split this lecture up into two, so I wasn't quite sure where the end slide was here. But the point being is that we want to promote dementia-friendly communities and responses, and just as a somewhat of a comment is that we're initiating as part of our HRSA grant, we're initiating caregiver training in our clinics where we've got a series of caregiver training modules where the individuals will go through a series of 6 training programs. And the idea is that it'll help them become better caregivers and also take care of themselves better so that they have less caregiver burnout and that we get better outcomes with the cognitively impaired either spouse or family